Hello, my name is Janine Wedeking, and this is a case presentation entitled A Graves Matter, Poor Weight Gain in a Breastfed Infant. Poor weight gain, also known as failure to thrive, is relatively common. It is estimated that 5 to 10% of children in primary care settings will be diagnosed with this. It is important as our ultimate goal is to prevent negative outcomes such as cognition, learning, behavior, and identify underlying poor social situations that might impact. Because the underlying etiology might be expansive, a structured approach can be helpful. As outlined by the American Academy of Pediatrics and the American Academy of Family Physicians, this can be separated into three broad categories. The first, inadequate caloric intake, the second, inadequate nutrient absorption, and the third, increased metabolism. Examples in the graphic below. Let's begin our case. The mom is a continuity OB patient of a resident in the clinic. She gives birth to a male infant at term. Her pregnancy is relatively uncomplicated and she has normal infectious disease labs in pregnancy. The infant is average for gestational age for weight and has a normal newborn metabolic screen. There are no other social concerns. At the 2-week well-child check, the infant is exclusively breastfed and has surpassed birth weight as expected. At the 6-week postpartum check, the mother has an etonogestrel implant placed for contraception, and at the 2-month well-child check, the weight decreased in percentiles. However, there are no other concerns and he is meeting all of his developmental milestones. Let's look at highlights along the World Health Organization growth chart. At the 4-month-old well-child check, the weight percentile has decreased again, and attempts are made to increase maternal supply with pumping and breast massage. At a weight follow-up, no weight gain in the infant is noted. He consumes 2 ounces during a weighted feed, which is less than expected for age, and no maternal lifestyle changes are identified, including excessive exercise, dietary changes, medication changes, or return of menses. At this point, the continuity provider for the mom and the baby goes on maternity leave and care for them is separate from this point. It is also recommended that the baby be given supplement express breast milk following feeds. At the 6-month-old well-child check, the weight and height growth percentiles continue to decrease. Thyroid function tests are obtained and are normal for age. At a follow-up weight check, the growth remains stable. Poor weight gain labs are obtained and are normal except for a mildly elevated ESR. Unknown to the providers, the mom starts to develop symptoms over the course of 4 to 8 months. She develops tachycardia, weight loss, dry eyes, neck swelling. Her thyroid tests reveal an undetectable TSH, elevated T4, and thyroid antibodies. In conjunction with endocrinology, she is diagnosed with Graves' disease and started on methimazole 10 milligrams twice daily. At the 9-month-old well-child check, the weight and head circumference percentiles continue to decrease. On the ASQ screener, the baby is intermediate in all categories. Mother labs are also obtained again. Her TSH remains undetectable, her T4 is elevated, and her dose of methimazole is increased to 20 milligrams twice daily. This is the growth chart side by side highlighting the same time frame. At the 10-month-old well-child check, the infant's weight and head circumference growth percentiles dramatically increase just 4 weeks after the methimazole dose is increased. The infant's labs are again obtained or within normal limits. The growth trajectory continues, and at 15-month-old well-child check, mom's labs are again obtained with an undetectable TSH and now a normal T4. Her methimazole dose is kept the same, and the growth trajectory continues even up to the 18-month-old well-child check. In considering the underlying etiology for poor weight gain in this infant, we again consider 3 broad categories. There's no obvious evidence to suggest inadequate nutrient absorption or obvious evidence to suggest increased metabolism. Therefore, it is suspected that it's secondary to inadequate caloric intake. With a normal exam and optimal social situation, we suspect it's secondary to inadequate breast milk. In consideration of infant factors, there are no obvious causes. And when considering maternal factor, the most obvious cause is the underlying maternal illness or Graves' disease. There are no human studies to suggest what hyperthyroidism does to lactation in humans. What we do have are rat studies. Capuco et al. In 1999 and 2008 demonstrate that hyperthyroidism in rats decreases the amount of milk that's let down at the letdown. It makes the milk-producing tissue involute at a quicker time, and sometimes malnourished states, even death can occur in the rat babies. The American Thyroid Association, based on the most recent 2017 guidelines, don't recommend treating maternal hypothyroidism on the grounds of improving lactation because little is known in this subject. When considering the underlying pathophysiology of Graves' disease that leads to a change in breastfeeding, we hypothesize that the hypermetabolic state in the mom can lead to a malnourished state in the mom if she can't keep up with metabolic demands. That in turn leads to changes in breastfeeding. One consideration might be changes in the macronutrient profile, less likely based on research. We know that lipids make up the greatest constituent of calories in the breast milk. Based on research by Juhas et al. And Insel et al., it is demonstrated that the lipid profile in the milk changes based on the maternal diet and based on the profile of fat in the adipose tissue they release during malnourished states, not actually a decrease in lipids of the breast milk. Another consideration is decreased volume of breast milk. In studies of malnourished mothers in impoverished nations, there's a relative reduction in breast milk amount rather than a reduction in lipids in the breast milk itself. Sosa et al. In 1975 demonstrates that chronically malnourished Guatemalan women, when they're given supplemental nutrition, will actually increase the breast milk volume and increase the duration of breastfeeding. Strode et al. In 1986 demonstrates that when mothers have less than 1,500 calories a day, their infants the following week will consume 15% less breast milk. This is all under the assumption or hypothesis that in a maternal malnourished state, there is a decreased breast milk volume, which leads to poor weight gain in this infant. However, due to a lack of human studies, there is likely other underlying pathophysiology of Graves' disease. In conclusion, the evaluation of poor weight gain should be individualized. Especially in breastfeeding infants, this means an individualized approach to the infant-mother dyad, which may include an observation of a breastfeeding session and a history, physical, and possibly laboratory evaluation of the mother as well. As previously discussed, at this time it's not recommended by the American Thyroid Association to treat hyperthyroidism to increase or positively impact breastfeeding. However, this is the first case to show that treating uncontrolled maternal Graves' disease can positively impact breastfeeding and may reverse or resolve poor weight gain if the etiology is Graves' disease. This also demonstrates the importance of family medicine care that is inclusive of the mother and the infant, and if employed in this case, could have identified and treated the etiology of Graves' disease sooner. Thank you.